Practitioners spend years learning to design precise musculoskeletal recovery plans, but the most sophisticated clinical advice falls apart the moment a patient leaves the clinic and stuffs the exercise sheet in their pocket. In the consultation room, the protocol is clear, evidenced, and agreed upon. At home, the prescribed routine simply doesn't happen. There is a quiet, persistent assumption among clinicians about why this breakdown occurs. We privately frame non-adherence as a failure of character, a lack of willpower, or sheer laziness. Treating a patient as unmotivated actively damages the therapeutic relationship. A patient who feels judged is not a patient who engages with their recovery. The reality is entirely different. These non-compliant patients are operating as neurologically normal individuals. Their inaction is not a motivational bug. It is the highly predictable outcome of two evolutionary cognitive heuristics that dictate exactly how human beings process risk and time. Overcoming this friction doesn't require a better motivational speech. It requires you, the practitioner, to design better decision architecture. The brain does not evaluate options on an even playing field. When weighing a new choice against the current reality, the current state gets a heavy thumb on the scale. Cognitive psychologists call this status quo bias. We evolve to survive, and survival requires predictability. The brain systematically overweights current stability over future uncertainty, because what is known is manageable. This visualization shows how that bias works in practice. The brain creates a shortcut where familiarity is falsely equated with safety. The path we are already on gets an artificial glow of safety, while the diverging new path is automatically coded as a risk. In a musculoskeletal recovery setting, the patient's current state is usually characterized by pain, but it is a known objective pain. Contrast that known pain with the intimidating uncertainty of starting a new physical therapy regimen. The new path might hurt in unfamiliar ways, or it might fail to work at all. Their neurological programming exerts a strong pull toward the familiar. Doing nothing, even if it means staying in pain, feels intrinsically preferable to the risks of attempting recovery. The preference for the familiar is only half the equation. We also have to look at how the brain processes time and prices future outcomes. This is governed by a second heuristic known as hyperbolic discounting. This graph maps how humans value outcomes over time. The brain exponentially devalues delayed rewards compared to immediate ones. A benefit in the future drops off steeply in perceived value the further out it sits. Think about the prescribed exercise. The discomfort of doing a set of agonizing stretches today sits right here, at the highest point of immediate perceived impact. That pain is concrete, it is certain. The decision-making centers of the brain register it as an immediate cost that must be paid right now. Now look at the payoff. The promise of regained mobility 6 weeks from now sits out here, resting near the mathematically negligible bottom of the curve. Standard recovery plans fail because of this exact mismatch. They ask the brain to trade highly concrete, guaranteed pain today for a future reward that feels abstract and mathematically meaningless. In a clinical setting, status quo bias and hyperbolic discounting do not operate independently. This matrix shows what happens when they combine. When you map the preference for familiarity against the preference for immediate comfort, they multiply, locking together into a tight neurological trap. The clinical math of physical recovery requires the patient to invest discomfort now to receive functional mobility later. That math runs in direct opposition to the brain's internal algorithm for processing time and risk. By avoiding the prescribed exercise entirely, the patient satisfies both heuristics at once. Inaction preserves the safety of the status quo and avoids the immediate penalty of discomfort. From a purely neurological standpoint, non-compliance is the most logical choice a patient can make. To break this specific compound trap, you cannot rely on verbal persuasion. You need a structural intervention. The Torbay chart is a form of targeted decision architecture. This chart tracks a patient's recovery journey using two precise metrics. We plot the patient's physical function on the vertical axis and time on the horizontal axis. First, we isolate the exact center point. This dot marks the patient's current physical status, establishing a concrete visual starting line. Next, we map the expected recovery outcome. If the clinical advice is followed, This upward line represents the trajectory of their physical function over the coming weeks. By plotting the distant reward on a visible axis, it concretizes the future. This directly counteracts the effects of hyperbolic discounting. An abstract probabilistic 6-week goal is transformed into an undeniable, concrete data point they can see right in front of them. Then we plot the alternative. If the patient does nothing, this downward trajectory represents the realistic decline in their mobility. This downward slope reframes the status quo. It visually proves that staying still is actually an active decline rather than a safe harbor. Laying out these intersecting trajectories transfers agency. The chart requires the patient to be an active reader of their own data, moving them from a passive recipient of instruction to an active participant in their outcome. The chart succeeds because it translates abstract medical advice into the exact visual language the brain requires to weigh risks accurately. This is a precise clinical mechanism. Its success relies entirely on exactly how it is executed, and personalization is the core driver. Practitioners must avoid using generic, uncalibrated curves presented as personal predictions. The data must accurately reflect the specific individual sitting in front of them. Patients are highly sensitive to whether a clinician actually understands their specific situation. If the trajectory feels cosmetic rather than tailored to their injury, the chart fails to build the necessary trust. The strategic integration of this tool also depends on the timing of the clinical conversation. Because the chart functions by transferring agency to the patient, the data points must mirror their subjective experience. Presenting options before a patient has articulated their concerns creates a disconnect where the tool feels like a generic clinical directive. The intervention is most effective when introduced as a direct response to a patient's stated hesitation, ensuring the visual evidence addresses the exact friction they are experiencing. Resolving patient noncompliance is achieved by restructuring the visual evidence of choices, ensuring that the path to recovery becomes the path of least neurological resistance.